Thank you very much for invitation. I'll share with you my experience. I have started intervention since 2005. And all my cases, actually, no one of them is because of acute MI. I have 4 cases of aortocoronary dissection. 2 of them happened with Jodker right, 1 with left ambulance 1.5, and 1 with Ikari catheter. And 2 left main, 2 RCA, and all of them in CTO cases, none of them with acute MI or with diagnostic. So I'll start 2 cases referred to surgery, and I would jump inside the OR with the surgeon, and the surgeon could not find anything, no problem. And he just finished the case with doing 3 vessels, cabbage, and that's it. So the 2 cases that I have managed inside the cath lab, this is the first one of them. This is a 54-year gentleman with strong family history of coronary artery disease. He had multiple BCI to the LAD, and for the last 1 year, he has angina. The CT coronary angio showed that he has significant lesion in the OM, CTO of BDA, and a metal jacket almost in the LAD. So the decision was to go for the RCA and to do the BDA and to do the OM and try to do something for the LAD if I can. And simply the antegrade approach for the BDA was successful with using double lumen microcatheter and stented and then DCB to the distal part. And you can see everything is good. Actually, when I start the procedure, you can see the other catheter is left ambulance 1.5. This is 7 French, and I was planning to go and engage the RCA, and then I found that engaged the left main, so I said, okay, let's go on. And you have seen the first image, everything was good. Now, after finishing this, I want to go back to the left main and try to manipulate the 7 French left ambulance 1.5 to the left main, and just by the fluoro, you will not see it now, you will not see it here. That's by the fluoro, I felt that something happened with the small injection in the fluoro. The dye was hanging there at the ostium of the left main. So I stopped giving more injections because I think aortocoronary dissection is not because of the catheter, it's not because of the manipulation. This is just a trigger. Most of it is due to the hydraulic dissection, but by injecting and more injection is the one which causes the dissection and laceration of the intima from the main vessel, either the aorta or the left main. So immediately, I pick up another catheter beside the left ambulance 1. This is EBU catheter. And I try to go with the wire beside the entrance or the way away from the entrance that the first catheter has done in between the left main and the aorta. And this is the way, actually, I think this is the safest way, actually, to avoid more dissection. So the wire was safely going there to the OM, as you can see here, and you can see and appreciate very well that I have dissection extending in the aorta and the left main, and maybe even extending to the OM and the LAD. So here you can see that the heart rate start to beat faster, and you can see that the left main is compromised, and you can see the alteration of the contrast between the true lumen and the false lumen. But my wires are in the true lumen, I'm sure of that, by the second guide catheter. So as you can see here, the first thing to do is to maintain the flow. I think in the aortocoronary dissection, the most important point is to maintain the flow to the coronary arteries is the first. The second thing is to avoid hydraulic dissection by giving more contrast and to stent the left main as soon as possible. So I changed the strategy, the strategy of the left main dissection to go to DK crash and all of these things, and blah, blah, blah. But now it is not the time. It is the time to fix the ostium of the left main. The left main has been fixed very well. And now to go the strategy, because there is also extension of the dissection in the left main, from the left main to the left circ and also to the LAD. So I fixed the lesion there in the OM. It is the priority. You change the priority when you have something happen. First priority is the patient life, the flow in the coronary arteries, and then not to cause more harm. And this is the way of get the wire, also double lumen microcatheter to go to the LAD. And as you can see here, that the aortic dissection is there. Everything has been corrected. So this is another strategy of stenting. Now the LAD, OM, left circ, and everything is safe. And you can see that even the heart rate of the patient went down, but you still see the aortic dissection, and it is maintained at that place. It is in the coronary sinus, below sinus junction, and not involving the cusp. So it left like this, and the patient had the follow-up, and everything was good. So my conclusion from this case is that when you use unusual catheter like lift and blast, especially with it is high grade like 7 French guide catheter, you need to be careful and you expect complications. Strategy of the stenting is to, the most important thing, not to cause more hydraulic dissection, fix the ostium, maintain the flow, and this is the way. This is my first case. The second case, if the time allows, my second case is, I call it the 3C case, CHIP, which is the cardiac high-risk patient, complex case, complicated complication. So 3C case, this is an elderly with high creatinine, impaired LV. Anyhow, he developed non-STEMI, and after that, nobody can touch him because of his high risk. So he came to me to do for him the cath. Unluckily, I'm the one who did this cath for him. And as you can see here, this is the e-carry guide catheter, and you see the left main. There is aneurysm in the left main, and also you can see that the CTO and the LAD, the OM has segment lesion, and also the RCA. So to stop here or to go in, the patient, after arrangement with the family and the patient and the surgeon and the team, we want to go for intervention. I want to go for the intervention, and as you can see, the e-carry guide catheter is there, and granuloplasty started, the wire passed, and what's the important thing to take from this point? Look at the catheter, how it jumped back. I think one wire or two BTCA wire to avoid aortocoronary dissection are not enough. So either to use the guide catheter, as Mohanad said, or the extension guide catheter, or to keep balloon actually there, so avoid the friction between the edges of the guide catheter and the edges of the left main and the aorta. Granuloplasty was tried, but also failed to open that very hard lesion in the mid of the LAD. So I choose to fix the OM and to stent it there, and to use that stent in the OM as anchor technique to stabilize the catheter and to go harder with the LAD. As you can see here that I'm keeping the balloon actually with the two safe wires or two BTCA wires. I keep the balloon between the tip of the guide catheter and the left main to avoid any dissection there, because I'm doing a forceful procedure here. Another granuloplasty failed, so I select to go even the microcatheter to cross with the rota wire did not failed. So I used to go with ADR and AFR techniques in the CTO, and to cross behind the calcium, and to go down, and to go with find the good knuckle. This is big knuckle, so the good knuckle, and then go with the double lumen microcatheter behind the calcium, and then went down, try to get the re-entry with getting the right channel and right track to go to the right, to the true lumen. And as you can see here that the tip of this hard wire actually is in the true lumen. So it is the time to exchange it and to avoid exit wire perforation, and to go with the soft wire by changing it with the double lumen microcatheter to single lumen microcatheter, and then stenting the LAD successfully. But as you can see here that there is a dye from the left main area to the aorta, and look at the dye there. Do you appreciate it? Do you see it? It is there. So what is going on? We'll go back to the first image. Look at the first image. And now, this is what happened. Is this a flow going to the aorta? Or is it aortocoronary dissection? Or in the aneurysm of the left main? So this is the dilemma. But to leave it like this, or to do something. I elect to do something. 1 minute more, please.
أعطوه 1 minute please.
أعطه الإكزس. So we were here. Look at this. The flow in the ostium of the left main is not good. So I elect to do this procedure just to short stent to the ostium of the left main. Have a still flow there in the circ. So I get to graft a stent actually here and deploy it at the ostium of the circ. To get this, the flow in the LED, you can see it is not good. So fixed lesion there. Now the flow is much better. Still I have some leak, but it is less than before. And that was the last image. So my conclusion from this case is even if you have high risk case, you go and maintain the flow and fix the aortocoronary dissection or the left main dissection with a stent.
Excellent, thank you very much.